Good afternoon, everyone. I'm Alyssa Reed. I served as Project Director for Global Learning for U.S. Primary Healthcare and will serve as the moderator for today's panel. Thank you so much for being here today. I'd like to welcome you to today's webinar describing a newly developed framework to support application of innovative ideas from abroad in order to improve primary healthcare in the U.S. and to explore some resources to support that work. Today's webinar is being recorded. Nearly 250 people are registered for today's webinar. In order to avoid background noise, all participants are on mute, so during the presentations, please submit questions through the Q&A function. Also, keep an eye on the chat for links to documents that will be referenced during the presentations. Next slide, please. Thank you. I'd like to begin with the land acknowledgement. Global to Local, which is hosting this webinar, is located in the Puget Sound area of Washington State, the traditional land and current home of the Coast Salish people, including the Duwamish, Puyallup, Suquamish, Tulalip, and Muckleshoot nations. And if you are participating from anywhere in the United States, you are within the ancestral or present-day territory of one or more Native peoples. While the topic of this webinar focuses on learning from abroad, we also honor the wisdom of Indigenous communities here and recognize that there is much to learn from their knowledge and experience. I'll post in the chat a link to a map showing the traditional territory of Indigenous nations throughout the US and encourage you to explore that if you're not already familiar with the land on which you are situated. This acknowledgement seems particularly appropriate given the topic of today's conversation, with the recognition of the importance of avoiding some of the colonialism associated with the past, and sometimes even the present iterations of global health and international health as we engage with local communities with good intent and humility, but not always with ideal execution. I'm going to put the link in the chat now so you can explore that. Next slide, please. Thank you. Let me now introduce today's speakers. Dr. Laurie Zephyrin is Vice President of Advancing Health Equity at the Commonwealth Fund. She is driven by a passion to transform healthcare and advance equity. Dr. Zephyrin brings her experience as a clinician, health policymaker, and entrepreneur to her role at the Commonwealth Fund to drive delivery system change. Prior to joining the Commonwealth Fund, she was the first National Director of the Reproductive Health Program at the Department of Veterans Affairs and served as Acting Deputy Undersecretary for Health for Community Care for the VA. Reverend Alex Plum is Director of Clinical and Social Health Integration at Henry Ford Health System, an ordained deacon in the United Methodist Church. His work transforms the institutions and infrastructure of the US healthcare system in order to achieve health and hope for vulnerable and marginalized communities around the world. Alex is a returned Peace Corps volunteer, a former Paul D. Coverdell Fellow, and Salzburg Global Fellow. Dr. Jonathan Sugarman is Senior Advisor at Global to Local and Clinical Professor in the Departments of Global Health and Family Medicine at the University of Washington. Over his 35-year career, Dr. Sugarman served as a clinician, researcher, consultant, and administrator in the Indian Health Service, community health centers, and several nonprofit health organizations. Dr. Sugarman serves as the principal investigator for the Commonwealth Fund grant that supported this work. Dr. Zephyrin will be the first speaker. Thank you so much for being here today, Dr. Zephyrin. We can go to the next slide, and I'll pass it off to you.
Great, sounds great. Thanks so much, Alyssa. Great to be here with everyone today. Really looking forward to this conversation today about global learnings for U.S. primary healthcare. Just want to talk a little bit about the Commonwealth Fund and why we decided to fund and support this work. If we go to the next slide, in terms of the Commonwealth Fund, we're a nonpartisan think and do tank founded over 100 years ago, and our mission is really to achieve a high-performing healthcare system that provides affordability, equity, and quality healthcare. And a key aspect of a high-performing healthcare system is a strong primary healthcare system that truly helps catalyze health equity. If you go to the next slide, our research at the Commonwealth Fund is focused in 4 key areas. One around achieving universal health coverage, advancing health equity, improving how care is delivered, and controlling healthcare costs. Next slide, we have 8 programs at the Commonwealth Fund, and for the Advancing Health Equity program on the next slide, this program was recently launched in January, and our work across advancing health equity is really cross-cutting across all of our 8 programs across the Commonwealth Fund, and is a key priority of the entire organization. But our goal of the Advancing Health Equity program is to eliminate unequal treatment, experience, and outcomes in health and healthcare for people of color, and by reducing systemic racism in healthcare policy and practice. And we have 3 focus areas, one around changing the mindset of healthcare leaders and professionals, and also promoting anti-racism in healthcare delivery systems, and promoting health equity impact in healthcare policies as well. And so part of really thinking about this work, if you go to the next slide, if you look at seeing some of the work at the Commonwealth Fund, we've done a range of work focusing in on comparing the US healthcare system to other countries. And if you go to the next slide, and we see that the US really has the highest healthcare spending when compared to other OECD countries or other like countries. And even though the US spends far more per capita on healthcare than these other countries on the list, Switzerland, Germany, France, Sweden, Canada, et cetera, if you go to the next slide, we see that Americans in the US experience poorer health and greater avoidable mortality than residents of many other nations. And we essentially rank last in terms of access to care, administrative efficiency, equity, which focuses on income inequality, and healthcare outcomes. And so there's a lot that we can learn when we think about looking at these other nations. If you go to the next few slides really just highlight just really the differentials in health system performance, and you see to the right where the higher dots are higher performing and the lower dots are lower performing, and you see US really in terms of system performance compares very low. And where we see this, if you go to the next slide, manifest is also in our maternal health outcomes as well. And a good portion of the work that we focus on in the Advancing Health Equity program focuses on systems and policies, and also maternal health equity. And as an OBGYN who's practiced in the past and delivered hundreds of babies, it's an issue that's near and dear to my heart. And when we look at maternal mortality and compare ourselves to other high-income countries, we see that our maternal mortality ratios are more than double of other high-income countries as well. And so when we think about why this is happening, if we go to the next slide, we know that we have to improve not only access to care, but also strengthen primary care and really extend it to every local community. And primary health care in the US is really at a financial disadvantage just because primary care spending is particularly low, even though we know that there's a strong amount of evidence supporting that primary care yields better outcomes, greater equity, and lower per capita costs. And so as we think about ability to learn from other countries and how the US healthcare system can learn from other countries, if we go to the next slide, we see that when we look at the top performing countries and poor performing countries, we see that top performing countries in health and healthcare have 4 features. One is there's universal coverage. 2 is they invest in primary healthcare. 3, there's reduced administrative burdens on patients and clinicians that can particularly discourage access to marginalized groups. And then 4, they invest in social services, meaning nutrition, education, childcare, transportation, et cetera. But the key point I also want to highlight here is that investment in primary healthcare and really ensuring that this primary healthcare is equity available in all communities, and really helping impact some of the challenges around equity as well. So if we go to the next slide, I've had the opportunity actually with Jonathan and with Ariadne to travel to Costa Rica pre-pandemic to really get a better sense of their primary healthcare system. And if you go to the next slide, And there are several low and middle income countries that really have great examples of primary healthcare, integrating primary healthcare and integrating that within communities. And low and middle income countries have much to offer the US about primary healthcare. And an important aspect of an effective primary healthcare system in low and middle income countries is, for example, far greater emphasis on engaging communities and prioritizing and addressing broader health problems. And so we published a co-authored a case study with Ariadne on Costa Rica's community-oriented primary care healthcare system. And it's built on 5 main pillars. And key pillar of that is really that engagement and integration with the community, which is really important as we think about primary healthcare and addressing health equity as well, really engaging and making the community at the center of health and healthcare. And we've also, if you go to the next slide, saw a similar model in the Cuban healthcare system. And having seen it firsthand, it was just really impressive to me just to see the community-based approach. And the primary care in Cuba, for example, is structured such that physicians can consider the health care needs of whole communities. And so that really had us thinking about what are other models within the US, for example, that where we can learn more about the integration of community as well. If we go to the next slide. I also think it's important, and Jonathan will talk more about this framework of applying a global learning to improve primary healthcare in the US and the importance of community. But I also think as we think about primary healthcare, it's also important to consider the many dimensions of how to integrate equity into primary healthcare. And primary healthcare has to really be responsive to inequity, has to incorporate trauma informed care, has to be culturally competent, and really think about the whole person as we think about equity oriented primary healthcare. And I also think if we go to the next slide, primary healthcare can be a catalyst to health equity in maternal health, really having that firm foundation for primary health care across the life course can really help strengthen outcomes as well. And last, I'd really just want to drive home that primary health care is a piece of the puzzle as we think about advancing health equity. It's also critical to address systemic racism, to ensure that there's universal coverage, to really intentionally address and eliminate health system bias, in addition to structural policy and system changes that can really integrate primary healthcare across the entire healthcare system. And so really, I'm really excited about this work that will be presented and really being able to apply a global framework to better understand how to improve the delivery of primary healthcare in the United States. And so looking forward to this conversation. Alyssa, I'll turn it back to you.
Excellent. Thank you so much, Dr. Zephyrin, for that very informative presentation. I'd like to now turn it over to Dr. Sugarman, and we can go to the next slide. Thank you.
Great. Thank you, Alyssa, and thank you, Dr. Zephyrin, for that very nice introduction and context setting for this presentation. During the presentation, I'm going to be introducing a framework for applying insights from global health here in the US. I'm going to be describing the contents of a recently published resource and implementation guide that's really intended to help support health systems and community-based organizations here in the US who are open to the applications of lessons from abroad to apply that to their local work. So in many ways, the objective of this is to stimulate some reflection about how you might go about doing this, whether you're a health system leader, clinician, a global health expert interested in applying your knowledge and expertise to help improve health domestically, or a funder who may be hoping to support others in applying lessons from across the world. I'll also start off by saying that we propose this framework as kind of a starting point to be improved upon, enhanced, or even superseded. So I hope and challenge the researchers and scholars on the webinar today to take a look at this with a critical eye and to improve this framework as time passes. First, though, I'll begin by sharing some background about Global to Local, which is the organization under whose auspices this work was created. Global to Local is a not-for-profit organization. For those of you who are calling from other countries, that's often known as an NGO, non-governmental organization. It was established in 2010 by a group of thoughtful representatives of several Seattle-based global health and public health organizations. Those included the Washington Global Health Alliance, PATH, the County Health Department, Public Health Seattle-King County, a multi-site community health center called HealthPoint, and Swedish, which is a large health system in the area. As you may know, Seattle is the home to many global health organizations, some famous ones like the Gates Foundation, Institute for Health Metrics and Evaluation, the Department of Global Health at University of Washington, PATH, but there are also many others that are less well known. Global to Local's founders reasoned that their global health expertise could be leveraged to improve health and health equity here, particularly for vulnerable and underserved communities, as Laurie was describing, that being a great opportunity. They were also aware of huge disparities within King County, that's the county within which Seattle is located, and found that these disparities were particularly striking in the southern part of that county. And so that's where they kind of hope to apply the experience of the region's global health institutions to help reduce health disparities. The founders began working in the cities of SeaTac and Tukwila, which are actually among the most diverse communities in the United States. Over 70 languages are spoken in the public schools. Half the population was born in another country, and about half also speak a language other than English in their homes. So if you ever fly into Seattle, you're flying into SeaTac Airport, and that's the location of most of the work Global to Local has done. In order to identify a topic or a place to start, the founders examined publicly available health data sets and identified these communities as having low immunization rates. They wondered whether the global experience in immunization programs among many of the participants could be applied here, and offered that to community stakeholders, but found that the community stakeholders were not terribly enthusiastic about that. Instead, the founding executive director of Global to Local, Adam Taylor, spent the better part of a year asking various community stakeholders what makes it hard for people in this community to be healthy. And they responded thoughtfully with things like poor access to healthy foods. We don't have an opportunity to exercise because they're on sidewalks. There's a lack of economic opportunity, lack of a seat at civic tables, and similar challenges to that. So in order to implement or to move forward with their mission to advance health equity and improve health in US communities through application of best practices from around the world, next slide, the Global to Local folks commissioned PATH to conduct a landscape assessment to identify global health strategies that are potentially transferable to the US. Now, this assessment was first done in 2010. It was updated in 2017, and they identified 11 strategies, 7 of which are shown in this slide. Now, it is clear that none of these strategies are totally unique to other countries, but the emphasis that is placed on them and the ways in which they are implemented elsewhere and prioritized can really be instructive to Americans. I believe that Alyssa can put a link to this document in the chat as well if you'd like to look at it a little bit more. Next slide. So how did Global to Local apply these strategies? Well, it did so in several ways. With regard to community health workers, in responding to concerns about, for instance, safe and culturally appropriate places to exercise, they developed exercise programs where cultural norms about modesty could be exercised. The community health workers also started off with a mobile phone-based diabetes management program in an effort to emulate similar approaches used in developing nations. In order to link public health and primary care, they developed a connection desk, a program to assist people in navigating health and human services resources, and co-located that with a primary care with a community health center clinic. Again, something that's typically done in many developing countries, not just having a clinical focus on these, but having other resources in the sites as well. Global to Local also hosted a food innovation network that has a couple of components. It has an incubator program to help immigrant and refugee food entrepreneurs establish businesses. Also, in order to address problems with access to healthy food, the Food Innovation Network started a series of local farmers markets. So this was an example of linking health and economic development. And these businesses now are flourishing at a now 1-year-old global food hall that you see pictured on the lower left of this slide. Those are just a few of the things I could go on, but I won't. I will say, though, it's interesting that the immunization idea has now come full circle because the Global to Local now, as a trusted community resource, has been working to provide COVID vaccines to the community. So what started off as an idea got rejected, now turns out to be something that's of interest to the stakeholders. Now let's go to the next slide. With that introduction to Global to Local, I'll turn to the main focus of this discussion. First, I'll describe the rationale for developing the guide that you see a picture of in this slide, and talk a little bit about the target audience. I'll briefly summarize for you the process of developing it, and then describe the components of the guide. So why did we embark on this work? Despite consensus, as reflected in Laurie's comments, about the value of looking abroad for ideas and strategies like those identified in landscape assessment, there really was no generally accessible and accepted roadmap to follow in order to know how to do so. That was certainly the case for my predecessors at Global to Local. I just joined the organization in 2018. But along the way, Global to Local accumulated a fair amount of experience, both in the challenges and opportunities associated with efforts to apply lessons from global health locally. In addition to testing and implementing its own approaches and activities over this decade, Global to Local staff also had the privilege of getting to know and learn from individuals from other organizations and institutions throughout the US who were working to apply lessons from across the globe to their work. So as Laurie indicated, in 2019, the Commonwealth Fund awarded a grant to Global Local to prepare some materials that could help other organizations apply global learning to improve primary health care in the US. Now, the primary audience for this was not really either organizations that are already deeply engaged in global learning or were experts in global health. Instead, the audiences were intended to be healthcare delivery systems, community-based organizations, who are at least potentially open to the prospect of looking throughout the world to identify solutions to local problems. Those are the folks who we really wanted to provide some tools and resources to. Now, it's possible that institutions who are already deeply engaged in global learning could find value in this work, but we really were trying to introduce this to not so much an expert group. So how did we do it? Next slide. In addition to reviewing its own activities and kind of the gray literature of Global to Local application activities, we convened an expert panel, many but not all of whom are pictured in this slide. This is a relic of the pre-COVID days when we actually had an in-person meeting of the expert panel in late 2019. In an iterative process that was informed by guidance and feedback from this expert panel of implementers and scholars in primary healthcare and global learning, Global to Local, the project team, developed a framework set of resources intended to outline this process that I'll be describing shortly. I will say that if you don't like the framework or the guide, to be fair to the expert panel, they weren't asked to endorse this approach. We couldn't take everyone's advice, partly because there was disagreement among the panel about what to include and what to omit. So any criticism should be addressed to me and not to members of the panel. Next slide. So let me talk for a moment about the components of this resource and implementation guide. It includes 3 major sections. The first is a framework for global learning that's accompanied by some examples in supporting resources. In addition, there's a self-assessment or reflection tool that's intended to help organizations understand and improve their readiness to apply global learning. And finally, a compendium of activities that organizations might consider as they work to apply lessons from global health. If you don't already have access to this guide, Alyssa will also put a link to it in the chat. I think it was included in the registration materials, so you'll find it there as well, I believe. For the remainder of this presentation, I'll walk through the framework, and after Reverend Plum's presentation, I'll briefly describe the reflection tool and the activities compendium. The next slide. This is a schematic, fairly high level schematic, which shows an overview of the framework. As you can see, it's composed of 3 primary domains or stages, each of which includes a couple of focus areas or change concepts. The first stage is focused on incorporation of a global perspective and openness to global learning. The second is focused on exploring global ideas. It's a little more a little more operational. It addresses approaches to identifying global innovations, particularly with emphasis on community empowerment and engagement for reasons I will address shortly, but Laurie already alluded to in her presentation. The last stage, which is about adaptation and implementation of global solution, focuses on application of lessons from implementation and dissemination science and diffusion of innovation theory to maximize the likelihood of successful adoption or adaptation of global innovation. So let's dig a little deeper into the elements of the framework and expand it a bit with the next slide. So the first stage encourages organizations to intentionally and actively consider seeking out and applying best practices and innovations from other countries. Includes 2 components, and we call them understand the why and understand the how. So we think answering 2 questions might help position organizations to apply global learning. The first is, why might it be helpful to look to other countries to improve primary healthcare here? The second is, what are the mechanisms by which global ideas can contribute to efforts to improve primary healthcare in the US? If we go to the next slide, I'm going to go over this fairly quickly for a couple of reasons. First of all, Laurie nicely already presented the argument related to comparative health system performance. She showed some evidence from both high and low and middle income countries. So that's one reason. Certainly, there's been already a great history of contributions of global ideas to US healthcare. For instance, what I would say is the crown jewel of the primary care system in America is the Federally Qualified Health Center program. That was really inspired by, in the 1960s, by health center approaches in South Africa that the father of the community health center movement, Jack Geiger, learned when he was a medical student. Finally, and this is kind of a tagline from the Robert Johnson Foundation Global Ideas for US Solutions program. Their tagline is, good ideas have no borders. That's clearly true in health. And it would only be provincialism that would be a rationale for us not looking abroad for ideas to apply. So why is probably not a very tough lift for most of the people on this call because you joined the call, but it actually may be for some organizations. The next slide, though, may not be quite as apparent, which focuses on the how. How can global learning contribute to domestic efforts to improve health and health equity? We think there are at least 3 relatively distinct ways in which global learning can be applied to influence us, shown on this slide. So the next slide shows the first of these, which is inspiration. So in some cases, simply exposing people to examples of how other countries have worked to improve health, even if the very specific policies, programs, or tactics aren't really easily transferable to the US, can inspire people to conceive and implement creative solutions to local problems. For instance, and Laurie mentioned Cuba in her slides. For many years, an organization called MEDIC, which has a program called the Community Partnerships for Health Equity, has arranged visits for hundreds of people from various low-income or low-resource communities in the US to Cuba to observe firsthand the Cuban healthcare system. So that context is quite different from ours, But exposure to things like Cuba's emphasis on prevention, integration of clinical care and public health have really stimulated the development of a broad range of successful programs among people who visited there. So here's an example. A group several years ago from Albuquerque visited Cuba and became familiar with the neighborhood consultorios, which were staffed by doctors and nurses who lived in the community where the clinics actually were, and therefore were very deeply embedded in the communities and able to provide services that were very culturally appropriate. So when they returned home, the Albuquerque Health Center could not directly adopt the approach of having doctors and nurses live in the clinic or in the community right next to the clinic, but it did inspire the team to establish walking groups for doctors, nurses, social workers, and others in the neighborhoods around which that were surrounding the clinic, in order to gain a deeper understanding of the community than they could simply within clinic walls, and to allow them to develop health programs that were more responsive to the genuine community needs. The next slide shows an example of strategies. A second way in which the global learning can help us is through the application of a general strategy approach that's been used in other contexts. So this example pointed out here reflects the work of Partners in Health, the well-known organization that's done work in some of the poorest regions of the world, Haiti, Malawi, Rwanda, Peru, and developed an accompaniment model of community health worker activity. And they ended up applying that accompaniment model in Boston to facilitate care of people with HIV/AIDS. Now, to some extent, it shared features of other community health worker programs in the US, but it really intentionally emulated various design features of CHW programs from other countries in which Partners in Health worked. So they took a global strategy and applied that locally, even though they didn't take a specific program and apply it. I'd refer you to that path landscape assessment I described a few minutes ago for other examples of general strategies. Next slide. So, excuse me, the third way in which this could occur is to look at specific interventions, programs, or tactics developed in other countries that can be pretty much emulated or directly transferred in some ways to the US. So an example of that might be a program called the Friendship Bench, which is an intervention developed in Zimbabwe by a Zimbabwean psychiatrist, Dr. Dixon Chibanda. He was responding to the fact that there were only 10 psychiatrists serving a population of 13 million people and no behavioral health service and primary care in the country, which was also understaffed. So we trained a cohort of lay community health workers, most of whom happened to be grandmothers, both to understand and diagnose certain behavioral health disorders, depression, related conditions, but importantly, to learn about and to administer problem-solving therapy through brief interventions. Several years after that, Dr. Mary Bassett, who at the time was New York's Commissioner of Health and Mental Hygiene and had worked in Zimbabwe and was familiar with the approach, worked with Dr. Chibanda to bring the Friendship Bench approach to New York City, where it was implemented in various neighborhoods. Now it was amended a little bit. It wasn't grandmothers there, it was trained peer counselors. But really it was a very similar concept implemented and brought from Zimbabwe to New York City. Now, of course, as this Venn diagram suggests, these three elements are not mutually exclusive. Every innovation may not neatly fall into one of the buckets. A single idea can certainly be a program that is an example of a strategy and is inspiring, but we do think that it's helpful to think of these as separate activities, particularly because when people think of applying global learning, they primarily think of looking for a project and seeing how that could get implemented here. So it's a little bit broader than that. The next slide. So the second stage is really more operational and tactical and focuses on identifying specific solutions. And in this, there's a particular regard or focus on community engagement and community empowerment. The second piece is to provide some resources to help people understand the sources of other ideas and innovations beyond community engagement. And I'll talk about those more in a second. So this is a little bit of a busy slide. I'm not going to be able to go into detail about each of the sub-elements under 2.1 and 2.2, but I'll spend a moment describing some of the key points. Now, the next slide, I think, is important. We have used the term primary healthcare, which is intentional and actually different from the term primary care, although the two terms are often conflated in the US. What you see in this slide is the internationally accepted kind of World Health Organization definition of primary healthcare, which includes three different components. Multi-sectoral policy and action, collaboration among all kinds of governmental and civic society organizations. Primary care, which is the first contact, comprehensive, continuous, coordinated healthcare and public health services, but also empowered people and communities as kind of a key element of primary healthcare and not something that's separate. So because of the importance of empowered people and communities, and the fact that it's one of the biggest opportunities for learning from abroad for US implementers, we've really focused a fair amount of attention on that in the resource and implementation guide. The next slide includes, just to stimulate some thought, a few examples of the types of resources that are included in the guide. For instance, actually, let me start off by acknowledging that there is certainly recognition in the US of the importance of empowerment, community engagement, and many organizations do it kind of well. As an example, federally qualified health centers in the US are required by regulation to have boards of directors whose majority is comprised of health center users. And that's often cited as a reflection of community control or empowerment in health centers. And while that may be the case with some F2HCs, research suggests that in many cases, power differentials between community board members and others who are typically professionals or experts who aren't members of the communities being served results in minimal meaningful engagement and community control over the design and delivery of services. So examples are included in the guide. This picture on the left is from a 13-country study that was conducted by the Training and Research Support Center that looked at different ways in which community participation in health could be implemented. Laurie mentioned Costa Rica and Ariadne Labs, and the document that they prepared is shown here as well. And just as a reminder, the World Health Organization has a huge trove of resources that is represented by the slide on the next one. Can we go to the next slide? So what are other sources of ideas for identifying global solution? Well, there are lots of them. It's one of the things we observed is that many of these successful application of global ideas and innovations in the US have been championed by people with overseas experience, former Peace Corps members, healthcare providers who had international experiences while training or had spent significant time in other countries as practitioners. Those are probably a great source of ideas for most American healthcare organizations and institutions because a growing proportion of trainees and others really has experience in global health. It's also the case that community members with lived experience can contribute as well. There's some examples in the guide of community-focused ideas that have come from members of communities being served. We also include several links to various special purpose websites that include lists of global innovations that can be searched by sector and topics. And I won't go into the details now just because we're short on time, but we'll say there are lots of ways to get access to these organizations. Finally, in this whirlwind tour, the next slide shows the third stage, which comes into play when specific programs or solutions have been identified as candidates for adoption or adaptation. And the guide includes summaries of and links to a number of resources from the fields of implementation science, dissemination science, and diffusion of innovation theory that have been or could be applied in order to successfully transfer global innovations to the US. There's a huge literature on transferring interventions from one location to another, although little has been really directly focused to transnational transfer programs, particularly from low and middle income countries to the US, but there are exceptions, as shown in the next slide. Here is an example of a tool that was developed by a team at the University of Toronto, which is kind of a brief assessment tool that helps assess whether or not interventions are really likely to be interventions developed in low and middle income countries are likely to be successfully implemented in high income countries. Let's go to the next slide, which shows yet another version of this implementation, diffusion of innovation theory work. Many of you are likely familiar with the work of Dr. Everett Rogers, who really was the pioneer of the field of diffusion of innovation. One of his colleagues and collaborators, Dr. Jim Deering from Michigan State University, and his team recently developed a model on how to design initiatives aimed at introducing global ideas into the US. So this would take a whole webinar in itself to describe, but I would commend you to that. Alyssa will place a link in the chat. So that's a very quick overview of the framework. And it was short on specific actionable examples and what it looks like in the real world. In order to flesh that out a little bit, I will turn the podium over to Reverend Plum, who will describe how one organization has applied many of the principles that are included in the framework that I've just run through. Alex?
Thanks a lot, Jonathan. And thanks again for the invitation to come and talk a little bit about this. At Henry Ford, we certainly wish we'd had a resource like this when we began our work in the global learning space. And I wanted to share a little bit today about how we've applied principles that have informed the creation of the guide along our journey to be reciprocal innovators by looking abroad to transform the healthcare landscape in the US, and particularly in Detroit, Michigan, where we're based. Next slide. Henry Ford Health System was started in 1915 by Henry Ford. He wanted a hospital for his employees. And as that industry and the auto industry grew and his work and production grew, he at one point bought 2 million acres or something of land in Brazil, in the remote parts of the Amazon, to try to harvest the materials for rubber so that he could make his own tires. And in doing that, he built a clinic abroad in Brazil that served his employees, including the Brazilians who were in his who were working that plantation, rubber plantation, and their families in the neighboring villages. And I like to point to that as one of the first opportunities that inspired Henry Ford's global learning, because while Fordlandia, and there's a really interesting documentary out there about it, was a complete flop, what it inspired in terms of the legacy of innovation, I think continues and lives on until today. And I think it's interesting because hospitals, health systems, the medical industry, as we know, as we've been demonstrating at Henry Ford, has a lot to learn by looking abroad. And I think we brought home the clinicians that went to abroad in the 1920s to serve that locale. I think they brought home some of that inspiration. In fact, in the 1940s, Henry Ford Health System, or at the time just Henry Ford Hospital, hosted an international symposium on cardiovascular disease and on heart surgeries. It was one of the largest of its kind at the time. And again, it permeated that desire and the interest in looking abroad. By 2014, and those efforts, I think, continued to grow and express themselves in different ways. But in 2014, a group of folks came together to kind of cement that legacy and to create an initiative or an institute that was interested in exploring how these global health solutions, the solutions from outside the United States, could be leveraged to change and to challenge how we delivered U.S. primary care. By 2016, the departments listed on the screen had really come together to facilitate that work. Work that had been leveraged, for example, infectious disease experts who were doing HIV, tuberculosis, co-infection research in Haiti and in India, folks from our psychiatry department who were interested in learning from Philippines and from Nepal, projects in Macedonia focused on pulmonary health. And how we leverage all of those learnings to improve through our population health, our primary health, and our community health departments, the delivery of care. Next slide. So, one of the things I think that's important to note as we kind of think about the work and how we let it, particularly at Henry Ford, is to acknowledge that a lot of us sort of have adopted what my friend Karobi Acharya at Robert Wood Johnson Foundation calls a blue marble thinking. And that picture in the upper right hand corner may be familiar to folks who are familiar with the blue marble quiz that the Robert Wood Johnson Foundation does. It was taken in 1972 by the Apollo 17 crew. It's the first photo to capture Earth in its entirety. And whether it was because some of us were Peace Corps volunteers, or because we grew up outside the United States, or were born outside the United States, the folks on the global health team, at least, are intuitively blue marble thinkers. Seeing that there is more that we have in common as sort of global citizens, that create a context by which, when we look at differences, they aren't challenging points, they aren't critiquing points, they're differences that exist because they allow us to look in and through cultures and countries and contexts to continue to complement and improve our world and our role in our world. And so I think it's that personal identity factor that informed a lot of how we were able to tell the story about why we represent Henry Ford's expertise internationally, and why we are humble enough to reciprocate that by letting our partners abroad be experts in their own rights and to share that expertise with us. I don't know if you know this, 1 in 4 people living in the United States today are either immigrants or children of immigrants themselves. And with over 33,000 employees at Henry Ford, it's not hard to think that a quarter of those folks are folks with some appreciation, a not insignificant appreciation, or a global perspective, and why applying that makes sense and is intuitive from their own perspectives. I'll say that living and working in Detroit reminded us that the challenges of providing care in a city that lacks regular resources. The city of Detroit is one of the cities that continues to, they've stopped because of the pandemic, but beforehand, one of the largest cities in the United States that routinely disconnected water from individuals who were too poor to pay. Our infant mortality rates in the city of Detroit rival Libya's. That's an oft-cited statistic. And so I think there was a sense in Detroit that things that were affecting residents of the city were realities that folks in the global South and lower middle income countries around the world deal with as a matter of course. And that just created the context by which talking about global learning, the phrase we used to use was reverse innovation, which I think, rightly has gone out of style, but this idea that we're going to create these reciprocal relationships was meaningful. And so I just wanted to highlight, particularly one activity that we did in 2015, shortly after I joined the Global Health Initiative, was to put on a symposium for members of the community to come together and to talk about how we could apply the UN's Sustainable Development Goals to questions of development in Detroit. And again, the folks that came, folks from grassroots community-based organizations, from our local universities, from the public health department, the mayor's office, folks from all over, it kept coming up that it was health. It was health, it was wellness, and it was the determinants of health and wellness, like access to a healthy environment, ability to walk, access to city services, to transportation, to childcare, that was driving their needs. And there was no question that if someone else outside the United States had an interest or had an idea or an innovation to drive that, that we should definitely look into that opportunity. Next slide, please. So we leverage that passion. We leverage that sort of stakeholder engagement from the beginning to do our work. Henry Ford, at least at that time, had relationships in something like 27 countries, either a physical presence or an ongoing funded partnership through capacity development or research and training. And that has grown over the years, but it was leveraging those relationships that allowed us to start to source and identify these innovations. I should acknowledge that my colleague, Dr. Kimberly Dawn Wisdom, Henry Ford's Senior Vice President for Community Health Equity and Wellness, is one of the early leaders in the United States healthcare system to identify and to promote a community health worker model to deliver care services. And one of those specific, our community health worker hub that still exists today, existed and was designed to address the infant mortality challenge. Because of that reciprocity opportunity, because we saw how, for example, in Cuba, how effectively the healthcare industry, healthcare system works to tackle such an intractable issue, and has, in very, very, very positive outcomes for mothers and their infants. I want to acknowledge as well partners in this space. I talked about Robert Wood Johnson, but the Commonwealth Fund was probably one of the earliest supporters of our work at Henry Ford in this. They, together with the Institute for Healthcare Improvement, brought 4 or 5 health systems together in 2014 and 2015 to winnow down a list of about 100 different healthcare innovations, and then to talk about how we could adapt from outside the United States, that how we could identify and adapt those 100 plus or so, to whittle them down to maybe 3 or 4, and then apply those 3 or 4 in our health systems, and really to kind of put into practice this idea about global learning. A lot of those were sourced through the Commonwealth Fund's Harkness Fellowship. And Henry Ford, we chose 2 of them. One was a more community-driven innovation to address loneliness and isolation. Another was a clinical focus on improving deprescribing or prescription optimization. And so that, partnerships like that, that had, again, goes back to the DNA of innovation in this space, as well as having the right funding partnerships and innovation partnerships, really helped create the context by which we could explore these global ideas and bring them back home. There's a bazillion other, if we had more time, we could talk about all the other great partners in this space that exist. I do want to just call out Krishna Dayakumar at Duke University's Innovations in Healthcare. They have a large compendium and have been supporting this work, and particularly the work of promising innovations in the Global South for a long time, and they've been great partners to us. But of course, the challenge with any of these things, and the more partners you get and the more work you do and the more innovations you identify, the larger your toolbox grows, the more we realize that we were stumbling into that dilemma that I like to call the shiny hammer problem, where when you have all these shiny hammers, everything looks like a nail. And so one of the challenges that we had was beginning to connect to make sure that the hammers we had, the innovations, that they were actually driving toward real challenges, clinical care delivery challenges, or challenges that our community partners and stakeholders had. And so that was sort of the next big challenge around linkage. Next slide, please. And so, as I said at the beginning of this, I wish we had had a model like this. We were building the plane as we flew it. And to some extent, you always are. Anytime you're living in this innovation space, these resources, these tools, these guides are incredibly helpful starting points. But they're atlases. They're not discrete Google Maps, right? And so some of the Fingerspitzengefühl that we have to use to apply our own methodologies to this, we want to respect that, right? So, I was trained in participatory analysis for community action, the sort of Peace Corps volunteer Bible at doing community development. Others on our team had other approaches to this. Jonathan mentioned Dr. Anil Bhattacharya's research and his criteria for applying innovations, and Dr. Deering's work in introducing global ideas through the model diffusion. And all of those at various times played a role in our work, and we applied those at various times and have been applying those at times. But at the end of the day, what has worked for us, what's allowed us to put skin on the bones was really to go back to our partners in the community, in our clinical settings, and to really just identify what those discrete clinical challenges were, and then to just kind of play matchmaker, to use technology to allow folks to talk to one another, to facilitate Zoom conversations and the like, just so that we could really kind of suss out details. We have a project where we've adapted a model from Nepal, from the organization Possible Health, now Nyaya Health in Nepal, where they deployed community health workers to assist in disaster areas and in areas where folks have been living with trauma from violence and war, and to work with them to use those community health workers to provide mental health care, but to integrate them into the primary health system. And we thought, we're not going to be deploying community health workers in mental health in quite the same way in Detroit, but we could use this model to inform how we design our work. And we've done that successfully. We are able to reimburse for that model now using a collaborative care model code. You don't, in Henry Ford, we don't want to rely completely on fee-for-service work, but even in value-based models, there are ways to make investments, and our system has been able to do that. So through adaptation, the critique that sometimes you lose fidelity to these original models is true, and we accept that critique. But as I said at the top, we never want to make the perfect the enemy of the good. And at Henry Ford, we've really tried to be inspired by our colleagues, to put them in the driver's seat, and then, to pay it forward, and where we can, to pay it back through our unique partnerships, through capacity training and development. And I wanted to say one last thing before I conclude, which is just that with Nepal particularly, they were one of the launching points for a program that we started in light of COVID that we call the Himalayan Home Care Program, where we're distributing COVID care kits to patients, where our partners in Nepal are developing and sharing these kits to patients, and using virtual care to do that. And we're one of their capacity expert partners in that space. Again, it's just a way that we create these partnerships, and so that bidirectionality, that reciprocity continues to feed itself. And let's just go to the last slide, and I'll just say that all settings won't have the resources that Henry Ford has, but that doesn't have to, because our work is illustrative. It's not prescriptive. Similar approaches can be applied because it's about the principles ultimately. Reciprocity and visibility for our partners around the world, especially at the bottom of the pyramid, especially in the global South. It matters. And really, one of the best things we can do to achieve equity is by humbling ourselves enough to step back and to accept that the U.S. healthcare system, as Dr. Zephyrin pointed out, has a lot of room to grow. We encourage you to define your stakeholders broadly but carefully, to think outside the box, but to have it be small and nimble enough that these projects can be piloted and we can learn from them. And my favorite piece of advice that anyone ever told me, which is just to not be afraid of failure, because you have to try, and it's okay to fail because there's always going to be learnings in that. So again, I just want to express my gratitude to Jonathan and the entire team for the ability to come and represent a little bit about what Henry Ford has done today. And I'm happy to follow up with folks offline as well on more of these topics. Thanks very much.
Thanks, Alex, for a great presentation. Now, obviously, Henry Ford's work predated the development of this framework and the resource guide, but hopefully it provides some validations, or is at least consistent with the model that we presented. Incidentally, the guide has a couple of other examples of Henry Ford initiatives that I think you might find interesting. We are getting short on time, so I'm going to quickly go through the next two slides, which is just to alert you to the existence of two additional components to the guide. One is a global health assessment tool, which is intended to help organizations assess their readiness and capacity to apply global learning to their work. And an example of what that looks like is here. The next slide shows a little excerpt from another component of the guide, which is a list of pretty practical activities that organizations might want to consider in order to move forward through various stages of the framework. They tend to be a little bit more actionable than some of the theoretical stuff in the framework. I understand that we're going to stay on for a little bit longer because we started a little late to allow people to dial in. So with that, I'm going to conclude and turn the program back over to Alyssa.
Thank you, Dr. Sugarman. All right, so I do notice we have one question in the Q&A bar, and we can get started. So please, right now, we only have a couple minutes since we're running late. Please type your questions into the Q&A chat at the bottom of your screen, and we will try to address as many as possible. Okay, so this first question, I believe, would be for Alex. Oh, and quickly, could all the panelists turn their cameras on? Thank you. I do believe this first question would be for Reverend Plum, although also Dr. Sugarman perhaps as well. So the question is, do you use implementation science guidance for adaptation and testing to fit local context?
Yeah, I mean, absolutely, we did. I think that was the piece around adaptation that we wanted to really hold to. I kind of said that toward the end, which is the perfect isn't the enemy of the good. And sometimes our approaches, or what we're trying to address, is too complicated to be to have a perfect full-on adoption of what one of the innovations was. I can think about our community health worker model in mental health. So instead, what we've done is we've just made sure that the stakeholders were engaging on both sides of, from the innovation side, the originating side, to the receptor side. Are sort of aligned on what the local challenges are, what the local challenge was that was being addressed, what we're trying to address, And then to understand if we're going to adapt, and this is where paying attention to implementation science is helpful, to really suss out how specific changes could drive, positive and negative externalities in that work. So we've applied that with different levels of rigor over the years of our projects.
And let me flack someone else's work now, actually, because many folks actually have directly applied adaptation methods from implementation science. For instance, our colleague, Dr. Yolanda Agbolo from the University of Maryland, Baltimore, has used an adaptation model developed by Sugarman and colleagues that helped her to implement a program in Baltimore that was borrowed from a program in Brazil to address social isolation. And while I'm thinking of that, I'll just say that University of Maryland, Baltimore has a program that's funded by the Robert Johnson Foundation called Global Learning to Advance Health Equity, and is developing a global learning health equity learning network. So although I think this is just getting kicked off and they don't have a website yet, you should keep your ears open, because they'll have other examples of implementation science application in this particular field.
Great. Thank you, Dr. Sugarman and Reverend Plum. Are there any other questions? Let me look at the chat too, but feel free to type them in the Q&A.
So in the chat, there is a link, I hope everyone can see that, to a series of webinars that the University of Maryland program recently hosted.
I see one raised hand. The question is, what about sustainment and scale up?
So is the question about, I say Alex unmuted himself so he can respond to this, but is the question about what kind of resources are required, or what kind of tools can be developed? So for example, the Deering model that we discussed is very much focused on scaling up implementation, and it uses diffusion of innovation theory and describes the factors that are associated with successful scaling up. Sustainment, I'm not quite sure about. Alex, do you have a response to that, or Laurie?
Well, I can just briefly say that we've made sustainability a big part of this effort. And as you can imagine, in the U.S. healthcare system, really a lot of this work comes down to one, it's either process improvement, so it's taking existing workflows or technologies and trying a new way of doing something, or if it really is a different level of care delivery, we have to consider reimbursement. And so those are always kind of questions on the forefront of our mind. And they've certainly, we try not to not do projects because we don't necessarily see a way if we can't pay for it. Sometimes the process of letting our partners be the expert and learning from them, even if we know we're not going to be able to sustain the care delivery aspect of this in the long term, it's enough for us it's inspiring, right? And it's a good way for folks to be able to apply some of the models. So I think it can be a both and sometimes, depending on the goal of it.
Just to add to that, I think there's a lot of opportunity in this policy environment in terms of sustainability. There's a significant focus on advancing health equity, the role of community-based organizations and community health workers. There's a range of funding that's in legislation that's already been passed or potentially will be passed that can really bolster the community health care workforce. And so I do think in terms of the sustainability piece, really leveraging the current policy environment as we think about these models, it presents a huge opportunity.
Thank you, Dr. Zephyrin and Reverend Plum and Dr. Sugarman. With that, we can go to the next slide. Unfortunately, we are over time for today. And so I encourage you to reach out to Dr. Sugarman via the email address located on the slide in front of you if you have any additional questions or comments about today's presentation or the resource guide itself. We thank you all very much for joining the webinar today, and we're so grateful that you took time out of your busy schedules to learn with us. Have a wonderful rest of your day.
Thank you.